Hi, this is Larry Bauer, Chief Executive Officer Emeritus of the Family Medicine Education Consortium, and I'm very excited today to bring to you a presentation by Dr. Diane Harper, a family physician at the University of Michigan. I happened to hear Dr. Harper at a meeting this spring in Dallas, Texas. It was the Family Medicine Leaders Conference, and she sort of blew everyone away with her presentation and her commitment to the vision that drives what you're about to hear. So I'm excited that she'll be presenting with us. Just to tell you a little bit more about her, she's a professor at the University of Michigan, as you can see on the slide. She has appointments in the departments of family medicine, OBGYN, bioengineering, and women's gender studies. So that's pretty fascinating background right there. She is the third highest author in terms of number of research publications about cervical cancer screening over the last 30 years. She's had major impact on the field. And she's the top US researcher in this field, which is very cool. And you will get a flavor for this as Dr. Harper begins her presentation. Dr. Harper, thank you so much, and I'm going to turn things over to you.
Thank you, Larry. It's a real pleasure to be here and a real pleasure to share with you kind of my life's work and passion about how to care for women and screen for cervical cancer appropriately. I'm going to start by talking about what the risk-based tenets are for screening, those things that we all have to agree to about what makes a good screen and what will we use, what will the benefits be, and what are we going to give up. The first thing is that preventing all cervical cancer is unrealistic. There isn't any screening test that has perfect sensitivity, and therefore there will always be a residual cancer risk following any round of screening. We're just not going to find it all. Reasonable risk is determined by current cytology alone benchmarks, things that we've been doing for the last 75 years, the every 3-year screening mark. And screening strategies that achieve equivalent or better reductions in CIN3+ incidence without an undue increase in harm is our goal. That's what we're aiming for. And 5, our optimal balance of benefit and harms occurs when equipoise is achieved between screening too frequently and finding just transient HPV or LSIL versus screening too infrequently and exceeding the interval cancer risk threshold. And finally, women who are at similar CIN3 risks should be managed alike, period. So with that, what we find is that in looking at cervical cancers, only about half of women who have cervical cancer are actually detected by screening. That women who have cervical cancer often are afraid to go for a screen. They often can't afford a screen. They often don't know where to go for a screen, and they often don't want to be treated by a physician. So I think it's very sad for us to think that over 100 years after the Pap test was designed, that still only half of the women who have cervical cancer have their cancer detected by a screening. This is even worse for our Black women, as you can see in this circle. This is all happening in the face of the fact that cervical cancer incidence in the United States over the last 20 years is not really changing. It really is pretty flat. We haven't made a lot of inroads with this. So the changing algorithms that we've made in cervical cancer screening have not had much of an impact at a population level. We know from lots of tests and lots of studies that Pap tests by themselves are 50% sensitive. They're really not a very good indicator of whether cancer is present or not. So we're going to improve on that. We're going to improve on how good the Pap test could be. It is a tool that's evolved to its maximum potential. It's a tool that is dependent upon a visual assembly of dead desquamated cells from the surface of the cervix that are completely subject to the interpretation of the viewer. So I'd ask you to take a quick look at what is in this top left-hand portion, top right-hand portion of this slide, and what kind of picture do you see? And then when you blow it up into a bigger picture, what you see is something very different that's there. So what we're looking for is, how do we move away from this? How do we move away from something that's so subjective as cytology? We now move to the root cause of what cervical cancer is, which is human papillomavirus, HPV. Almost all cervical cancer is caused by persistent HPV infection. Prevalence and distribution of the HPV genotypes vary by the disease state. I'm going to show you that in a few minutes. And for most cancer precursors, the percentage that is HPV 16, 18 is much smaller than the 12 other HPV genotypes combined. That means those types are really important. This is going to show you a picture graphically that shows you kind of how messed up our system is by the use of cytology as a stratifying mechanism instead of something like HPV. So we're going to start first with all possible screens that come forward, and then we're going to separate them out by how often they occur. So normal, this negative for intraepithelial lesion or malignancy, that is caused, that happens in almost 96% of our cytology reports. Of those 96% of women, 12% of them are positive for a high-risk HPV type. And of those high-risk HPV types, you see that 16 and 18 are a very small percentage compared to all of the other types. There are only 29% of them that are 16 and 18. When we go to the atypical squamous cells of undetermined significance, they occupy about 3.5% of all of our women, 3.5%. But of those ASCUS reports, half of those women are positive for high-risk HPV types. And about the same, 31% are positive for 16 and 18. But what you see is an almost even distribution of the other 12 high-risk HPV types as well. Then we move to a low grade. We see that only about 2% of women have a low-grade report, but of those women, 76% are positive for high-risk HPV types. Well, if LSIL is supposed to be an indication of an active HPV infection, why are only 76% of them positive for high-risk HPV? Well, the answer to that is that the other 24% are low-risk HPV types. Those low-risk HPV types also cause this low-grade epithelial change, which is not something that will go on into a cancer. Then we have our final one, which is high-grade lesions, and that's 0.3% of our cytology reports. And of those, 85% of them are high-risk positive. And so you might ask, why are 85% of those and not 100% of those high CILs positive? Because we know that you have to have HPV in order to have a CIN2-3 lesion. Well, the reason for that is that HSIL as a diagnosis on cytology is not very good. And many times that HSIL is a completely normal cervix. It's not a very specific way of stratifying women who are abnormal. But we do know that 85% of them are positive for high-risk HPV types. And we know that almost 60% of those are caused by HPV 16 and 18, a much bigger percentage. So now you've seen this total mix-up of cytology with HPV types. And to give us an idea of how messed up cytology is as a stratifying mechanism, we see that 75% of our CIN2-3 cancer precursors come from an ASCUS-LSIL cytology background. So if instead we had been looking at this from an HPV background, we would very clearly see the progression of HPV 16 and 18 become a larger and larger percentage of those high-grade lesions. So instead, what we're trying to do now is move away from cytology as part of our stratifying schemes. We know that HPV prevalence is changing. We know that 80% of women will have an HPV infection sometime during their lifetime. We know that vaccination uptake is increasing. We know that females and males are getting closer to the 70% vaccine threshold. We know that vaccination is effective for at least 14 years, and we actually now have evidence that it prevents invasive cervical cancer when given younger than 17 years of age. We know that vaccination is a bridge to screening. We know that it gives people enough protection until they can get into the screening system. And the fact that HPV prevalence is decreasing makes HPV screening a better test. It actually improves the specificity of the test. So the recommendations by our national and international boards for cervical cancer screening has now changed. The most recent recommendations from the World Health Organization recognizes primary HPV testing as the only test to be used in women 30 to 65 years of age. This happened in 2021. The American Cancer Society also very boldly came out in April of 2021. Based on the evidence that we have seen and the evidence I will be supporting and showing you today, that primary HPV testing for women 25 to 65 years of age is a much smarter way to screen women for cervical cancer. The United States Preventive Services Task Force in 2018 included primary HPV testing in addition to the traditional co-testing that we've been doing and cytology alone. They made a very specific statement that greater detection of SYN3+ with fewer tests were required, the most efficient with HPV 16 and 18 genotyping as a triage test. So in other words, if we have primary HPV testing, we can find SYN3 more easily with an HPV test that allows us to triage to HPV 16 and 18 once it's positive. And the American College of Obstetrics and Gynecology does include it as its test recommendation, although it still includes co-testing. Primary HPV testing is an NCQA HEDIS qualification for meeting your cervical cancer requirements. This is important for those of us in clinic practice where we actually need to know that the screening we do counts towards our points for being able to show population health care. The data that shows that primary HPV testing works has been done by our European colleagues by randomized controlled trials evaluating primary HPV testing for cervical cancer screening. These are the different studies that have been done around the world, the different number of rounds, the number of years women have been followed. This is very, very well researched with very strong data indications that primary HPV testing works. I will show you that. In the United States, we do not have any randomized controlled trials. We have an industry-sponsored observational trial called Athena. We also have the Kaiser Permanente Northwest group that is publishing data with the National Cancer Institute to show primary HPV testing works. Both of these are observational groups. This uses the data from the Netherlands trial, from the Pabascum trial for 14 years. And what it did was take the 43,000 women in this population who were between the ages of 29 and 61 years of age, and they set them into three groups: a group who would get just cytology, a group who would get just HPV testing, and a group who would get both cytology and HPV testing. And they tested all these people, and all of the women who had a CIN3 lesion at baseline was taken out of the study. So according to each screening arm, all women were negative for CIN3. And then they followed women by their respective screening strategies over the next 15 years. And what they found is over the next 5 years, not many people develop SYN3+. But in the next 10 years of screening, what we saw was a dramatic increase in the number of CIN3s detected, but not so much in the number who have been screened with HPV testing or co-testing. Now, the reason for this is not because cytology is so much better at finding SYN3, it's because cytology is so much worse at finding incident SYN3 infections at baseline. The fact that many women with SYN3 were left in the database and that were continued to follow over time and finally were detected in this second 5 to 10 year screening interval. So what this shows us is that looking at the red line, the women who were screened with HPV testing alone had an ability to detect the new incident SYN3 infections that were new CIN3 lesions that were forming over this time frame, and that they were able to be detected. What the green line shows is that those women who were negative for cytology and HPV testing had a tiny fraction of better detection of SYN3 over time. Now, my point to you will be that this is a point that many people will argue that co-testing must remain in place and that HPV testing will miss some people. And my posit to you today is that difference is not clinically or statistically significant. The United States Preventive Services Task Force used all of those countries' 14 years worth of data and separated this out into harms, lifetime number of tests, lifetime number of colposcopies, false positive results, and cancer cases or deaths, and compared that to the benefits such as life year gained, disease detection, and cancers averted. And they looked at this for different possible schemas for screening in the United States. They specifically published 19 different possible screening mechanisms. We're going to focus on the 3 that are highlighted today. The green, the first one, strategy number 2, starts with cytology every 3 years for women 21 to 29 years of age. For women 30 to 65 years of age, they switched to co-testing every 5 years for those who are negative. You can see that that results in 11,425 cytology tests per 1,000 women, 8,380 HPV tests, for a total of almost 20,000 tests, resulting in 1,630 colposcopies, detecting CIN3 of 54, and having a cervical cancer cases of 1.08 per 1,000 women. When we compare that to strategy 8, which is the second green highlight, that is the same early cytology screening every 3 years for 21 to 29, but now we use primary HPV screening and we follow that by HPV 16, 18 genotyping for triage. We see that our total number of tests is down to 12,000. We see that the number of colposcopies is about the same, the number of CIN3 plus detected, and the number of cancers is about the same. And again, we do that with looking at primary HPV screening with cytology triage, again, showing us about the same number of cytology tests with HPV tests, giving us the same number of total tests, the same number of CIN3s detected with a low number of false positives and a same number of similar cancers detected. This all allows us to be able to show that compared to co-testing, in measuring the harms versus the benefits, we see that primary HPV screening, whether you triage with 16 or 18 genotyping or whether you triage with cytology, gives us a 60% fewer tests to find the same CIN3 plus disease. This is really remarkable why we haven't changed to this right now. The countries that are currently using primary HPV testing, if it's not nationally, then certainly it's regionally, include these 14 countries. We see that we are really pretty far behind the curve in being able to recognize the evidence and the data as presented and the scientific validity of moving into this testing schema. So I'm asking you to change your current practice. I'm asking you to say, let's start with primary HPV testing. And then we'll know that 90% of our women will be negative, and they can come back in 5 years for another primary HPV screen test. We know that 2% of our women will be positive for 16 and 18, and they will go straight to colposcopy. And we know that 8% of our women will have 12 other high-risk HPV types, and they will be triaged right now with cytology. And if that cytology is ascus or worse, they will go to colposcopy. This is such a simpler screening algorithm than the algorithms we've had in the past. Now women are going to have options. They'll be able to say, Am I an average risk asymptomatic woman? And can I do a primary HPV testing that potentially could even be a self-screening? Or do I want a speculum-based exam that I have to go into the office for? The Last Mile Initiative is a program that NCI is sponsoring. I am part of the clinical trial sites for this. We are looking to get self-sampling for HPV testing to improve our cervical cancer prevention. We aim to enroll approximately 9,000 women who will have both a clinical directed exam and a self-collected exam. And we aim to present this data to the FDA. And if the data is so supporting, ask for FDA approval. We hope to have this finished within the next 3 years, so you can be looking in your practices to the potential to offer your women a self-sampling test that they can do either in the office or at home in the near future. So then you have the choice of what are you going to offer your patients who have a cervix? Are you going to offer them an office-based speculum exam where you do co-testing? Or are you going to offer them a primary HPV testing, which detects the greatest number of SIN3s with the fewest tests required? Or are you going to switch to potentially a self-sampling exam when this becomes FDA approved in the future? I'm going to offer you an interim step that will allow you to move from co-testing to something that isn't quite as scary, but gives you much better detection of our SIN3+ for much smaller costs. This is changing from a speculum-based co-testing exam to primary HPV genotyping with a reflex to something called dual staining. This is an economic model that I did. Background to tell you, we know that HPV testing became approved by the FDA in 2003. We know that in 2012, the recommendations from USPSTF and ACOG and the American Cancer Society moved co-testing to an every 5-year interval. We know that in 2014, Roche and in 2020, BD, both received FDA approval for primary HPV testing for women greater than 25 years of age. So we know that this is all appropriate and that we can do primary HPV testing right now in our offices should we choose to do so. This is the current algorithm, our current standard of care that we have here at Michigan. Yours may look very similar to this. What I want to stress with you is how complicated this looks. You start off with a genotype, high-risk HPV, and cytology, and depending on what the HPV result is and what the cytology result is, you have 4 different possible classifications you have to remember to send the lady to colposcopy. You have 12 other types that come back in a year. We have HPV negative, but an LSIL that comes back for 3-year follow-up. And then we have our negative HPV test and our ASCUS or NILM that lets her go to a 5-year routine screening. This is what we currently do. This is our current standard of care. There may be some variations on it, but pretty much this is what everybody does right now with co-testing. What we're proposing is this much simplified version. Let's base it on HPV results. If she's 16 or 18 positive, she goes to colpo. If she's 12 other type positive, she goes to a triage test. If she's HPV negative, she goes back for 5 years. That's really simple. If this triage test, this dual stain test is positive, she goes to colposcopy. And if it's negative, it gives her reassurance. If it's continually negative, she does not get stuck in that go to colposcopy loop that has so often trapped many of our women. This provides a much simpler way of managing women and detecting their SIN3+ in an appropriate manner. This is what we did. We had a microsimulation model. We had 49 different plausible patient groups. We categorized people in 3 different particular groups. By age group, are they by 5-year intervals, 25 to 29, all the way up to 60 to 64. We looked at what is their HPV status? Are they negative? Are they 16, 18 positive? Or are they 12 other positive? And we had 5 histology outcomes. They're normal, they have CIN1, they have CIN2, CIN3, or they have invasive cervical cancer stage 1. We did 250 microsimulations for each patient group, which amounted to 12,250 microsimulations for each model run, which took about a day and a half of computer time. And what we considered for each person we put into this microsimulation model was how old they were, whether or not they'd had an HPV vaccine. The population was weighted to the US population so that we could address health equity questions. We exited the women from screening at the age of 65. And we took into consideration those women who had CIN2-3 lesions that then were treated and had to continue in screening at an every 3-year interval for the next 25 years. The model inputs, we looked at the test characteristics of screening. So HPV, how many people did HPV screening miss and how many people did they overdiagnose? The procedural characteristics, the costs as derived from a third-party payer in 2021 US dollars. We did use a time discount rate for the costs, but not for the quality of life. I personally don't feel quality of life should have a time discount. The model outputs that we saw per 1,000 women screened, we're now comparing primary HPV genotype screening with the standard of care that you saw. So that really simple algorithm versus that really complex one. And what we saw is that the number of screens was reduced, the number of colposcopies was reduced, the number of leaps was about the same, but the number of colposcopies per CIN2-3 were definitely smaller, and overall costs, it was cost savings. So if we have primary HPV genotyping and we use a reflex dual stain, we require fewer screenings, fewer colposcopies to detect the same number of CIN2-3 disease at significantly less cost than co-testing. If we look at the risk of invasive cervical cancer, we see that high-risk HPV genotyping reflects to dual stain for our 12 others, gives us a reduction in cervical cancer, invasive cervical cancer. So it lowers the risk of invasive cervical cancer, again, with no change in life years or quality adjusted life years compared to co-testing. So why are we still using co-testing? The summary here is that dual triage meets the triple aim. Our triple aim is high quality of healthcare, the health of the population is high, and we want to reduce healthcare costs. So right now, in this preliminary stage, primary HPV testing done with the speculum exam in the office can be sent for dual stain triage, which meets our triple aim goal. It maintains high quality of life, reduces the numbers of tests and colposcopies, reduces the risk of cervical cancer more than our current standard of care algorithms, and reduces the overall screening test. So with that, I'm going to conclude and say, what are you going to offer your patients with a cervix? Are you going to keep doing co-testing? Are you going to offer them primary HPV testing? And are you going to triage them with cytology or even with dual stain as an option? And once we have the average risk asymptomatic woman approved for self-sampling, we'll have primary HPV screening with these biomarkers as options for self-screening for cervical cancer in the near future. I thank you very much for your attention, and I'm more than happy to have you email me with questions. I'm more than happy to discuss with you the ability to make these changes in your own offices and in your own clinics. Thank you, Larry.
Oh, thank you. Would you like to mention your email address at this point?
Sure. So it's Harper, D-I, H-A-R-P-E-R-D-I at med.umich.edu.
Fantastic. And, you know, it's been some months since I saw that you present this originally. And I have to tell you, it's just as powerful now as in person. So thank you very much for that. I did have a question for you.
Sure.
So as I mentioned at the beginning, based on that article that you shared with me, you are the top US researcher in the field of cervical cancer screening, and you're in the top, the third highest author worldwide. How do you account for that productivity? You know, a lot of people believe, medical students and others believe, that family medicine is not very active in research, and here you are being world-class. Well, how do you account for that?
I have to say that it's an underlying passion. Family medicine is patient-centered. I care extremely about my patients, And I specifically have a soft spot for women's healthcare. And when I see women inappropriately treated or being subjected to too many tests or things that just don't quite make sense to me or don't seem right, I just have this unerring personality trait that I have to go answer. Why? I am trained in science. My sister will tell you I was a science fair geek growing up. But it's this overwhelming desire to use science to ask questions and answer questions with the perspective of the patient in mind. And while I sit amongst a really amazing group of illustrious people and scientists within this field of cervical cancer prevention, I will say that what I bring to the table that they don't bring is the patient's perspective. My colleagues are amazing researchers, PhD researchers who spend all day doing research. And I spend time actually with my patients in the clinic. And so I feel that having that voice is so critically important. I encourage all of us in family medicine, find your inner questioner, find your inner curiosity and ask questions, and don't be afraid to keep asking questions. Don't let people shut you down, because that's the only way you keep moving forward. And it's the only way we bring the patient perspective to some pretty intense, rigorous scientific discussions that people are like, yeah, why do women care about what the biomarker is? It's not that specific biomarker, but it's what the biomarker can do to make that woman's life so much easier when it comes to screening. So I encourage people to foster that part of themselves that I know is there. We all have that curiosity about why.
Well, that's fantastic. Thank you very much for that.